Hi, this is Maxine, and this is your online presentation on hematology. And we're going to cover some specific issues related to hematology in here, including we'll talk about bone marrow biopsies. We'll look at myelodysplastic syndrome. We'll look at thrombocytopenia and leukemia as well. Before you proceed, if you haven't already followed my directions below this video and talked about downloading the blank PowerPoint presentation and printing it out, I would recommend you do that so that as I'm speaking you can take notes. My slides have, some information on it, but there are a lot of things that I've said that aren't going to be on the slides. So if you just print the slides out and not listen to this, you're going to be missing out on a lot of information. And I hope you enjoy this presentation. The associated reading assignments for this section are in your IGGI textbook, and this is out of edition 7. So if you have an older edition, you're going to have to use the index and find the corresponding pages. But in the 7th edition, you'll read page 879 through 892, specifically the topics from myelodysplastic syndrome all the way through leukemia, and then pages 895 to 896 regarding platelet disorders. There's also a nice video that I have attached, both a link here, which you won't be able to access in this mode, but if you use the printable attached version of PowerPoint and run it through slideshow mode, you'll be able to access this link. Or to make things easier, I also have a link below that'll take you right to the YouTube video. It's about 6.5 minutes long, and it really explains a lot of information about leukemia, so feel free to watch that. The objectives for this particular portion of hematology are to discuss the reasons for and the nursing care for a patient needing a bone marrow biopsy, as well as identifying the appropriate nursing management for patients with myelodysplastic syndrome, thrombocytopenia, and leukemia. Before we go on, let's just take a really quick review of the anatomy of the bone and the bone marrow. So we all should remember that the bone marrow is responsible for producing stem cells, and those stem cells differentiate out to different types as the body needs. So it's responsible for making red blood cells or erythrocytes, white blood cells or leukocytes, as well as platelets and other immune system cells. Now with that in mind, let's look at a bone marrow biopsy. It's a very useful diagnostic tool where a small amount of bone marrow is extracted, and it can help diagnose a number of different diseases such as anemia, thrombocytopenia, leukemia, and other malignancies, as well as myelodysplastic syndrome. Most often the cells are taken from the posterior iliac crest, but they can also use the anterior iliac crest or the sternum. This procedure can be done at the bedside in the hospital or in an office or lab using just local anesthetic, or if necessary conscious sedation or general anesthesia would be used, but that would have to be an inpatient hospital procedure. Now we'll take a look at the nursing care involved with a bone marrow biopsy, and we're going to separate it out into 3 sections: the pre-procedure care, the intra-procedure care, and the post-procedure care. So first thing we want to do is make sure that a consent has been signed and is in the patient's chart. And that's not our job to get, but it is our job to make sure it exists. And if not, we need to remind the doctor or the provider who's doing the procedure that they need to consent the patient. And then it's our responsibility to make sure the patient fully understands the procedure, and we provide a little bit of support. Next, we're going to help with positioning of the patient, and they can be either side-lying or prone, depending on the provider's preference. But let's make sure that the patient is as comfortable as possible. This shouldn't take too long, but some doctors might have a harder time finding and extracting the correct amount of bone marrow. So they could be in this position for 20 to 30 minutes. So use positioning and pillows to help them get some comfort. And lastly, we're also going to provide emotional support for the patient. Even though they do use a local anesthetic, there is going to be some pain and discomfort involved. So we want to make sure that the patient is relaxed, that we're providing support. I like to use a little guided imagery to help them, get them in a good frame of mind and a good place. The intra-procedure responsibilities for the nurse are really to administer any medications that may be ordered, such as lorazepam or Versed, especially if they're using conscious sedation. If possible, we'd like to give them some pain medication prior to the procedure starting, but it's really going to depend on what the doctors have ordered. And again, the use of guided imagery or auto-hypnosis is a really powerful tool, and it's something that the nurse can really help the patient work through, get their mind off of where they are, and really helps to reduce the pain and discomfort that they're going to feel. It also helps to distract the patient. So just talking in a nice, calm, relaxing voice is very important in this procedure. Hold the patient's hand, or if available, allow the significant other present to help with that support. And finally, we're going to assist with handling of the specimen that's removed, the bone marrow specimen, and that's going to be according to your hospital protocol. In some cases, the provider themselves might be the ones that take responsibility for the specimen, but you need to be aware of what your responsibilities are with regard to that. And then post-procedure, we're going to need to assess the patient frequently. So assess them for signs of infection, such as fever, increased white blood cells, any swelling or pain associated with the site. And the pain should diminish as soon as the procedure has completed. We're also going to assess for signs of bleeding, and we can do some other comfort measures such as applying ice to the site and administering other mild analgesics such as Tylenol as ordered. Now let's start to look at some of the disorders that might be diagnosed based on the bone marrow biopsy. And the first one we're going to talk about is called myelodysplastic syndrome. And this is actually a group of disorders caused by abnormal bone marrow. It's often considered a precancerous state, as it may eventually develop into leukemia, and it has some of the similar signs and symptoms or clinical manifestations you'd find in leukemia. So this is a decrease of blood cells, and it's going to decrease all produced blood cells. So it causes a state called pancytopenia, meaning all of your blood cells are going to be reduced. So you're going to see anemia, which is a reduced red blood cell, hematocrit, and hemoglobin. You're going to see thrombocytopenia, which we'll discuss shortly, and you'll see neutropenia, so a significant reduction in white blood cells. When all three of those anemias are present, that's what's called pancytopenia. The etiology of myelodysplastic syndrome is really unknown at this time, but it is thought to be possibly autoimmune. And the risk factors involved are generally folks over the age of 60 are at a higher risk. Smoking will increase your risk. Chemical exposures to things such as pesticide or benzenes may increase your risk, as well as chemotherapy. Myelodysplastic syndrome is diagnosed, as we talked about just previously, through a bone marrow biopsy, and it looks at the chromosomes within the bone marrow to determine that this condition exists. Treatment for myelodysplastic syndrome include allogenic hematopoietic stem cell transplant, and that's really only done when nothing else is working for this patient, and it's really rarely done due to the risks and typically the advanced age of the patients. So you might see this done more for a younger patient should they develop this syndrome, but again, it's got a lot of risks involved. So it's not something that they take and do very, very often. The majority of the treatment is really supportive therapy. So they might need to get blood products such as red blood cells, white blood cells, or platelets transfused. And when we talk about blood transfusions in class, we're going to talk about patients who get a large number of blood transfusions are going to be at higher risk for reactions, transfusion reactions. So these patients are going to be at high risk for that. There are also some medications that can be given, erythropoietin stimulating drugs such as Epogen, Procrit, Aranesp, and they can also get injections to help increase white blood cell production as well. Now let's take a look at thrombocytopenia in a little bit more detail. There are essentially two different types we're going to discuss, but basically the definition of thrombocytopenia is a reduction in the available platelets necessary for clot formation. So the first type we're going to look at is called idiopathic thrombocytopenia purpura, ITP for short, or otherwise known as autoimmune thrombocytopenia purpura. So basically in this form, the platelet production is normal. What happens is the circulating amount of platelets is reduced due to antiplatelet antibodies causing a macrophage destruction of these platelets. So the production is normal, but their body is attacking those platelets and thus reducing the number that are available in our blood for that clot formation. This type is most common in women, ages 20 to 40. And because it's an autoimmune disorder, the likely cause is really thought to be a viral infection, but the exact etiology is pretty well unknown at this point. So the clinical manifestations you would expect to see in a patient with thrombocytopenia are ecchymosis, petechial rash, bleeding, and anemia. And if you think about the cause of this disease process, they kind of make sense. So if they don't have enough circulating platelets in their blood, they are going to be at a higher risk for bleeding. So the development of ecchymosis or bruising, petechial rashes are pretty much expected. Bleeding, you're going to want to look for both occult and frank bleeding, so any nosebleeds, blood in the urine or stool, which might be occult or meaning not very visible, or they could be frank bleeding. And any other signs of bleeding. Probably these patients will need to be put on some type of bleeding precaution. And they'll also have some anemia. So we'll learn about this more in class with regards to anemia, but they're going to pretty much have all those symptoms. So the treatment of the nursing care for a patient with thrombocytopenia include a number of medications that might be given individually or in conjunction with each other. And some of these have some side effects that need to be thought about. But again, they have to, the provider when they order will weigh the risks and benefits and determine what, if any, of these medications need to be given. So you might see them on a corticosteroid, which would be used for anti-inflammatory processes. There's another medication, azithromycin, which is actually used to treat various autoimmune disorders, but that one does tend to have some bone marrow suppression as a side effect, so that's something to be thought about in these patients, especially if they have the thrombocytopenia as a result of some already bone marrow issues. The third medication is rituximab, or Rituxan is the name brand, and that's actually a chemotherapy drug that is oftentimes used in the treatment of thrombocytopenia. And finally, romistoplasm, which helps to increase the circulating platelets in the blood. They also might be treated with IV immunoglobulin, or IVIG, which helps to prevent further platelet destruction. They may need transfusions of platelets, although this normally isn't done until their platelet count is less than 20,000 and symptomatic, or 10,000. So even though the platelet count is normally somewhere in the range of 150,000 to 400,000, we would expect to see some thrombocytopenia if this is their diagnosis. So we're going to expect them to have a low platelet count. And we normally just kind of watch and take kind of a conservative approach to transfusions. But again, the numbers that are most generally used are less than 20,000 and symptomatic, meaning they're having some bleeding issues, or less than 10,000. And again, we will be putting these patients on bleeding precautions when they're in the hospital, and we're going to teach them about bleeding precautions at home, such as using electric razors, applying extra pressure whenever they have a cut or wound to make sure that the bleeding has stopped. And if they're unresponsive to other treatments, one of the more drastic measures might be a splenectomy. And the second type of thrombocytopenia that we're going to talk about is called thrombotic thrombocytopenic purpura, or TTP. This is actually a rare abnormal clumping of the platelets in the capillaries, which leaves a shortage of circulating platelets in the bloodstream. Again, it is thought to be an autoimmune response, and it's a response to endothelial tissue in the blood vessels. So again, it's the body's own, treating these tissues as foreign, and therefore it thinks there's a problem and it's going to start clumping the capillaries to form clots in these capillary beds. Because of that obstruction of blood flow, it's going to cause ischemia in the tissue, which is going to cause pain and other such symptoms. It can lead to organ failure, renal failure. The clotting and clumping could lead to myocardial infarction as well as CVAs. Because of the serious nature of it, it can be fatal if it's not caught and treated quickly. So some of the treatments for this particular type, including a process called plasmapheresis. Another potential treatment is the infusion of fresh frozen plasma, and that's going to provide some platelet aggregation inhibitors back into the bloodstream so that these little microclots stop forming. Some medications can be given as well, including aspirin, so the antiplatelet properties of the aspirin will help. Alprostilil or Prostine can be given, and then plicamycin, which is actually an anti-neoplastic drug, or a basically a chemotherapy type of drug. And let's move on to the last disease process we're going to talk about in this module, and that is leukemia. So the definition of leukemia, I've actually stolen some words verbatim off of the National Institute of Health website, but it's essentially a cancer of the bone marrow resulting in an uncontrolled or excessive production of immature white blood cells. So the NIH describes or defines leukemia as, again, a blood cancer, begins in the bone marrow and the soft tissue in the center of the bones where the blood cells are produced. The term leukemia actually means white blood cell. So this is where white blood cells, which are normally produced to fight infection and other foreign substance, are actually made in an increased amount. And one would think that that might not necessarily be a bad thing. If you have, an excess amount of white blood cells, wouldn't that mean you're better able to fight infection? And actually quite the opposite is true. These cancerous cells, they actually prevent not only healthy red blood cells and platelets from being produced, but it also prevents mature white blood cells from being made. So these, large number of immature white cells actually are detrimental to the patient, and that they're not capable of fighting infection. So even though the white cells are high, they are at a huge risk for infection on these folks. And they may have some life-threatening symptoms that are a result of this condition. The cancer cells spread through the bloodstream and the lymph nodes. They can also travel to the brain and spinal cord, which is called metastases, affecting the central nervous system and other parts of the body. Now, before I get too far into my discussion of leukemia, this is a very specialized type of disease process, and not all nurses are going to be oncology nurses. So unless you're going into this field, you really only need to focus on the basics, understand some terminology, understand the basic types of treatments available. Leukemia in itself is a very complex disease process with a number of different forms. So I'm going to give you some basic information that should really help you understand a little better. And you don't really need to delve much further into what we're going to talk about in this presentation. So leukemia is really characterized or broken down into several different terms. There is the acute and there's the chronic. And within both of those states, it's further subdivided a little further. So let's just first talk about the acute. As with anything in medicine, acute basically means sudden onset, short duration. Whereas chronic is more of a long-term, slow onset. Symptoms could persist for months to years, okay? Underneath each of these acute or chronic states, we have two other differentiations, and that's basically the pathway with which the cell development and the cancer develops. So there's lymphocytic and there's myelocytic. So if we look under the acute type, if we look at acute lymphocytic or lymphoblastic leukemia, it's abbreviated ALL for acute lymphocytic leukemia. In general, your acute types of leukemia are going to have a poor prognosis, but not necessarily, very poor. Like in this case, acute lymphocytic, it's generally found in younger patients, children, and it can have a fairly good prognosis if it's caught and treated early. However, if it's caught, later on and once symptoms are persistent and metastases has occurred, then you're going to have obviously a less likelihood of a good prognosis. If you look under the chronic lymphocytic leukemia or CLL, that is again more often seen in the adult population. And being that it is a chronic form of leukemia, generally speaking, it has a better prognosis. And again, it all depends on when diagnosis is made, when treatment has begun, and how the patient responds to that treatment. Going back under the acute, we look at the myelocytic or myelogenous form of leukemia, AML. Contrary to the ALL, which is more often seen in children, this one is generally seen more in the adult population, and it does tend to have a poorer prognosis. It's one of the probably worst forms of leukemia that you can get. Whereas the CML, the chronic myelocytic leukemia, that one can actually be seen in either adult or children population. Not a huge distinction was made. It has a better prognosis. At least it's found that the survivors will have at least 2 or more years post-prognosis as long as it's, again, found and treated appropriately. So let me just quickly recap again on leukemia. So it is a overproduction of these immature white blood cells, which are also called blast cells. And these blast cells, which are produced in the bone marrow from those stem cells, because that has significantly increased, it's going to reduce the number of red blood cells and platelets, resulting in anemia and thrombocytopenia and all the symptoms that are associated with those problems. These immature leukocytes or blast cells are incapable of providing adequate immunity against invaders or infection, leaving the patient severely immunocompromised. The exact etiology of leukemia is really unknown, but some of the risk factors that we've been able to identify at this point are exposure to ionizing radiation, which may be from other cancer treatments, some chemical and drug exposure, again, such as like chemotherapy agents that are given for other cancers, may put patients at higher risk for developing leukemia. Bone marrow hypoplasia, which is a reduction in the bone marrow cell production, and that is something that's seen in a disorder called Fanconi's anemia. Or, as we talked about earlier, the myelodysplastic syndrome is sometimes known as a precursor to leukemia because patients oftentimes will advance down that road. And then there are some genetic factors that also may put patients at higher risk, such as Down syndrome, Bloom syndrome, and Klinefelter syndrome. Now let's look at the clinical manifestations or patient presentation that you might expect to see in these patients. And again, none of these assessment findings are going to be normal. However, they are normal things you would expect to see in a patient with leukemia. So first we'll look at the inguinary system. So because we have these reduction in platelets and red blood cells, you're going to see signs and symptoms that are associated, such as petechiae, ecchymosis, paler, especially in their nail beds, conjunctiva, in and around their mouths. In the cardiovascular system, you would expect to see some tachycardia, maybe some orthostatic hypotension, heart palpitations or murmurs, or those dysrhythmias that patients they'll complain about the fluttering in their chest. In the gastrointestinal system, you would expect to see some anorexia or loss of appetite, which will bring on obviously weight loss. There might be an enlarged liver or spleen, bleeding in the gums, and constipation. In the respiratory system, dyspnea on exertion and an increased respiratory rate would be expected findings. Neurologically, we might see the patient reporting headaches. They may have seizure activity or coma, and they're going to probably have some fatigue. That's more associated with the anemia. And in the musculoskeletal system, there'll be some bone or joint pain and probably some swelling as well. Some of the diagnostic testing include a CBC, and we would expect that the hematocrit, hemoglobin, and platelets are going to be reduced. We already know that there is a decreased production because the bone marrow and those stem cells are mostly being used to produce excess leukocytes or white blood cells. So we're going to see that the patient's going to be anemic, that they're going to have some thrombocytopenia or reduced platelets. In the white blood cell, we would expect low, normal, or high, depending on the phase they're in. And that's something that you would learn more about if you decided to go into oncology nursing. Initially, white blood cell counts are going to be significantly high, but mostly filled with these blast cells or immature white cells. Typically, the higher that number is, the poorer the prognosis. White cell could start to normalize, and then it's definitely going to go low once the disease has progressed or when treatment has begun. The bone marrow biopsy is really the gold standard. It's the most definitive test for leukemia and any other bone marrow problems. And coagulation studies are probably going to be done, and they will most likely will show an elevation, meaning patients are slower to clot, and again, that's because of the reduced number of circulating platelets. Now let's look at the nursing care associated with leukemia. And I'm going to give you a lot of information on this slide, and I don't want you to overstress about it. My main point here is to really have you be able to recognize certain terms and certain treatments that are associated with cancer, and in this case specifically leukemia. But again, unless your plan is to go into oncology nursing, I'm not going to test you on specific medications or drug therapies, but I want you just to be able to recognize the different types of treatments and then understand, most importantly, what does that mean for the patient and how is that going to affect the care I'm giving. So with all that we've said so far about leukemia, it shouldn't be a surprise to you that the priority nursing diagnosis in most cases is going to be risk for infection. And that's related to the diminished immunity. As we've been saying, they have this elevated white blood cell, but they're immature white blood cells, hence they're unable to fight off infection. So it's really going to put these patients at an increased risk for infection. So that is really going to guide a lot of our nursing care. On top of that, chemotherapy, which is one of the treatments for it, is going to put them at an even greater risk for infection. So again, I'm not going to necessarily test you about the different types of treatment and therapy and medications, but I want you to at least to be able to recognize these terms and kind of know what they mean. So usually chemotherapy for leukemia is broken down into induction or initial therapy and then consolidation therapy. So induction is generally it's the initial treatment, and it's really meant to look for remission or a slowing of progression of the disease. Consolidation is more of continuation, long-term therapy, and that's really geared at more of a curative type of a treatment. You can look in your book for specific drugs. It's usually a combination of drug therapy. Most of the medications or the chemotherapy drugs are very difficult to pronounce, which is why I'm not going to embarrass myself and try to say them here. But feel free to look them up if you're so inclined. But one thing to remember is side effects for most of these chemotherapy drugs are pretty similar. So we're looking for issues of neutropenia. So having a lower than normal neutrophil count, which is, again, those are the white blood cells that are most prominent in fighting infection. So when they're neutropenic, they're going to be at that really great risk for infection. Nausea and vomiting is a very common side effect with almost all chemotherapy drugs. Diarrhea, alopecia, or the loss of hair. As you start to learn more about chemotherapy drugs, you note that they're geared in most cases to target very fast growing cells, which is very typical of cancer cells, but so aren't certain cells in the body, such as those that produce hair follicles. So that's why you get the alopecia or the loss of hair with chemo. Stomatitis, which is painful mouth sores. Kidney toxicity, liver toxicity, and cardiac toxicity. These are always things that have to be monitored very closely for chemotherapy treatment. Graft versus host disease is a potential problem with any type of like stem cell replacements, or certain medications can cause these. It's potentially a life-threatening complication for a lot of these treatments. Consolidation, again, curative. It's a lot of times the same drugs, but different dosages or combinations as what's done in the induction phase. And again, part of the consolidation therapy can include stem cell transplants. And when they do stem cell transplantation, before they can embed you with the new stem cells, the new bone marrow, they basically have to eradicate all your existing. So this puts them at a, basically they can't produce any blood cells for a period of time. Which really, these patients have to be in protective isolation for a longer period of time and really monitored closely for these. And when you're talking about stem cells or any type of a transplant, there can be various different types. There's the hematopoietic, which are cells that come from an anonymous donor. There are autologous cells, which are their own cells that are collected and then reimplanted. And again, the graft versus host disease, because they're oftentimes on immunosuppressant medications, that is something that really has to be monitored for. Another one of the big things, the big key points you need to be aware of for treatment of leukemia is this neutropenia. So when we're looking at their white blood cell differential, oftentimes you see it in their labs. You'll see percentages of the breakdown of the 5 different types, and you'll see absolute counts, which has the number sign after it. And it's really the absolute neutrophil count, the ANC, that we're looking at and most concerned with. The normal, I believe, is somewhere around 4 to 8. So when we start to become concerned when we see that it's less than 2,000, and we definitely will put them on a neutropenic or a reverse isolation for anything less than 1,000. One of the treatments we can also offer them to help their body naturally produce more white cells is Neupogen. Just like Epogen or erythropoietin injections can help stimulate red blood cell production, this Neupogen can help to bring on the production of more white blood cells when they become neutropenic. And then we're also concerned with thrombocytopenia, which is that reduced number of platelets. And again, we would expect them to have some thrombocytopenia when they have leukemia, and our normal, platelet count is 150 to 400,000. And we would expect them to be much lower than that when they're leukemic, but we really don't become concerned or overly concerned until it becomes really less than 20,000 and symptomatic, or less than 10,000, and that's the point where we might be considering transfusing. these low counts, this severe neutropenia and thrombocytopenia, they can occur at a point in treatment that is known through the oncology world as nadir, and that is the low point of bone marrow suppression. That's really when the numbers kind of bottom out and drop down to their absolute lowest, when they're at, again, the most risk of developing infections and other complications. And we as nurses need to be really cognizant about monitoring and protecting our patients when they're at that point. Before I go on to talk about some other potential nursing diagnosis, I know I got a little winded on the previous slide, so let me just back up a minute and talk real quick about neutropenic precautions or protective isolation, because this is really a big thing to think about with these patients. When they do get to the point where their neutrophil, their absolute neutrophil count is definitely 1,000 or less, and sometimes if it's even less than 2,000, and we're concerned about somebody being at an increased risk for infection. What that means for us is we're basically protecting the patient against our bacteria, our normal flora. As long as we utilize good hand hygiene and we don't have any potential infections, active infections, and specifically upper respiratory or respiratory infections where we think we might contaminate or expose our patients. Really standard precautions are fine. Good hand hygiene. No protective gowns or anything is really necessary. However, we need to make sure that all healthcare providers, as well as any visitors who potentially could bring these bacteria in, who might have some type of a cold or respiratory infection, need to wear at a minimum a face mask when they're with the patient. By the same token, when the patient leaves their own hospital room and they're going to be exposed to any number of people, for their own protection, they should also be wearing a face mask. Some patients might be very adamant about insisting that we wear gloves and gowns as well. Nothing wrong with that, but it's really not something that is essential. However, what is critical, and one of the key points I want to make here, is we need to make sure that we don't expose them to any potential bacteria. So think about things that could potentially bring bacteria close to the patient. So fresh fruits and vegetables, flowers, living or otherwise, even things such as potpourri or anything that might potentially be carrying bacteria, should not be brought into the patient's room. And that's something that you really, as a nurse, really need to make sure happens. Okay. With that being said, let's just talk very briefly about some other potential nursing diagnoses, and I'm not going to go too in depth with them. You can work these out on your own as far as your related tos and potential nursing interventions, but these are all things that you should be well aware of. It's not specific to leukemia patients. So the first one being pain. Cancer in general, especially if it's metastasized or it's causing lesions or anything, is going to cause pain. So that needs to be addressed. Risk for bleeding, that should go without saying. If they have a reduced blood cells, red blood cells, and platelets, it's going to put them at an increased risk for bleeding. Fatigue, again, anything that's associated with anemia, which we'll talk about in class, they're going to be extremely tired, shortness of breath. Activity intolerance is going to be a huge problem for them. And the risk for deficient fluid volume. Okay, that kind of wraps up my presentation. There's another video just after this on your course website that's on leukemia. It's about a 6.5-minute video. Please feel free to watch that for some additional information. Don't forget to read the article regarding blood transfusions and watch the skills video on giving blood transfusions. That's it. I hope you enjoyed the presentation.